We face in our life so many occasions where we feel nervous. What's the difference between, being nervous? Let's say my boss is shouting at me, my wife is screaming at me at home because I'm late and so on, or I am under, starting arguing with people. Could all of these kind of things bring an anxiety or bring a panic attack by itself? Can I reach that point?
This is Dr. Suleiman.
I guess.
This is my boss. So how I can answer to my boss? I need to be careful,
Yes,
Okay.
yes, sure.
So thank you. I know you're asking for the audience. So basically, the anxiety I will start with: is it harmful or beneficial? So question from the audience. Can we? Anybody have any comments?
It can be harmful, and it can be harmful when it's excessive and pathological, and it can be beneficial when it's just physiological anxiety. For example, getting ready to sit an exam, it's good to have a little bit of anxiety to get you prepped before that exam, but it's harmful when it's in excess and for reasons out of the ordinary.
Very good, excellent. I mean, I'm very impressed with my audience. What I'm gonna teach you guys. You guys know already like a basic concept of the anxiety. Okay, no, this is very true. The anxiety, mild to moderate, it will be coming in the next slides. Mild to moderate is a helpful, beneficial, and moderate to severe anxiety is a harmful. Like it can decrease the performance, it can decrease the the well-being of the person, and it can even lead to the not being able to do anything, and it can start affecting the social, occupational, and other areas of life in life. So this is the quick outline. So as we said, that the anxiety is a protective mechanism. It's a normal physiological protective mechanism. It prepares an individual for real or imagined threat. You remember that when we are when we are standing at the side of the road and we are trying to take the step on, as soon as we put the step on the zebra crossing and we see there is a car flying, although they can stop, but I mean, it gives us a severe kind of surprise, and we immediately feel our heart starts beating fast and breathlessness and things, and that is a physiological mechanism preparing the body to fight or flight mode. Like, what should we do? Should we cross the road, or should we protect ourselves, go back? So this is the mechanism basically happening. This is the extreme example. A deer in a headlight means, I mean, usually in the US, when we were experiencing, like in the middle of the road, you can see at the night, the deer stands in the middle of the road and stare at the headlight, and they don't move. And God forbid, sometime the accident happened. What does it mean is, when at the night time, the deer look into the headlight, the strong light, the severe rush of anxiety and the adrenaline make him freeze, and he cannot move. He or she cannot move, and the accident. So this is the extreme example of very, very severe anxiety. This is like a stunning kind of situation which happens in real life. Can be very, very dangerous. So this is the reason to put this slide. So just to give some idea about the biological aspect of anxiety, areas of the brain, amygdala and anterior hippocampus are usually associated in the regulation. So they are not showing the picture. It's covering. Okay. So this is the cartoon showing some of the areas which are involved in the anxiety. You don't need to memorize, but just to have an idea, the different connections in the brain which are affected during the anxiety mechanism. So anxiety prevalence is pretty high in the adolescent years, maybe 25%, even maybe more post-COVID. I don't have any data post-COVID. There is a much more. I'm seeing a lot of in the clinical practice, we are seeing a lot of people coming for the anxiety. So these are the rough numbers. So the risk factors for anxiety, as you can see, there's a male preponderance, except the OCD, the early life trauma is a risk factor, chronic illness, chronic stress, and borderline personality, cluster B personality type has a more risk of anxiety. And it also runs in the family. Substance abuse is a risk factor for anxiety, but there is some debate on the substance abuse because people think there's a one group of professionals feel that the people who have anxiety, they tend to use more substances, alcohol and drugs, and they feel better. It's kind of self-medication, and those people feel temporary relief, and use of substance continue cause increasing in anxiety. So this is the, both ways, self-medication and having an anxiety, but definitely the substance abuse can increase the risk of having anxiety in future life. So anxiety is the most frequent reported type of psychopathology across all three age groups, the child, adolescent, and early adults. Anxiety is a state of mind which can lead to uncomfortable feelings, resulting in physical symptoms, as we described before, emotional symptoms, irritability, anxiety, low frustration tolerance, feeling angry, and there are some attention focus issues in some people when they are severely anxious. So we are going more concrete on the physical symptoms like headache, nauseous feeling, irritability, rapid heart rate, breathlessness, feeling panicky and sweating. Some people also experience numbness or feeling tingling sensations and so on and so forth. Emotional feeling, anger, feeling of helplessness, disappointment, and cognitive symptoms, difficulty concentrating, thinking negatively, and the cognitive distortion is a well-known phenomena in severe anxiety. So these are the different systems: sympathetic system and parasympathetic system. In anxiety, the sympathetic system is hyperactivated, the parasympathetic system usually relaxed. So just to give you an idea, some of the things happen which is already mentioned in the physical symptoms, physiological symptoms of the anxiety. So this is a very famous story I had. This is a real life story. 11-year-old girl has multiple site pain like belly aches, shoulder pain, headache, throwing up for 2-3 months, and the testing was negative, including the endoscopy. So in fact, and she was on 7 medication. In fact, this girl was referred to me by one of my senior colleague, pediatric consultant. And when he saw this girl, and he said, Dr. Tahir, there's something not right, because she's on a lot of medications. All the tests are negative, but still she's not getting better. I would like you to look at her and see what happens. When I took the history, and the important thing in the history was like a recent change. The family moved from North America to Dubai, and she lost her friends, and she didn't like being here, and so on. Weather changes. They moved from Toronto, I think. And I still remember, this is quite many years ago, this case. So when I explored her, I find out she has anxiety. So anxiety has many faces. So this is one of the most important thing, that to understand that all the earlier consultants, physicians, pediatricians, they were trying to treat the shoulder pain, the headache, the vomiting, and belly aches, and so on and so forth. And nobody actually took the careful history, I would say. So this girl was put through a lot of tests and a lot of medication, and the result was none. So when I took charge, this girl, I took the thorough history, met with the parents and everything, and I kind of felt that she has a generalized anxiety disorder, which has been grown much worse over the period of months, and these medications were not helping. So she was treated. She was treated with the SSRI and with the psychotherapy, and she showed improvement in 4 to 6 weeks. She was feeling much better. She started like going to school and not complaining of any headache, throwing up, or anything. So the reason I put this story is that because many times we may be misled, we may get misled and are misguided by the physical symptoms. So anxiety can present in many, many different ways. I understand that this is the diagnosis of exclusion, but it should be in the mind when we are taking the history and we want to find out exactly what's happening. If the symptom doesn't make sense to you, this means that there's something else going on, and we can do that. There are other stories. For example, the patient have a palpitation, shortness of breath, feeling numbness, feeling unexplainable pains, and they go to the hospital with the chest pain. They do the ECG, echo, and the cardiac enzymes, everything is negative, and then they say, go home, you have nothing, which is not the correct response from the doctor. They should say, your all cardiac tests are negative. It seems like you don't have a physical problem, but maybe you have something mental, because if person is saying I'm suffering, this means there is something going on which I don't know. I could not find in the labs, I could not find in the testing done. So they need to look into the mental health part if there is anything else going on which is treatable. So the different types of anxiety, I mean, generalize, I will give just the, I mean, I think it's a very common symptom, but just I want run over the symptoms of the generalized anxiety. This is excessive, mean disproportionate worries about anything and everything, like grades, families, family issues, parent safeties, and financial issues. People having this type of anxiety, maybe they are hard on themselves and they judge themselves, or they are strict disciplinarian or things like that. The children present with multiple somatic complaints, frequent headache, bellyache, the one we had the example before. So this just to know, give you a hint how it can present in a clinical setting. So panic disorder is, the panic attacks, like having a palpitation, sudden onset, shortness of breath, numbness, sweating, breathlessness, abdominal cramps, heart. It's different people present differently. So the difference between panic attack and panic disorder is that, like, if you have a symptoms but you are not afraid of having another attack, this means panic attacks. But if you have symptoms, this kind of symptoms, and you are afraid that you will have these symptoms again, or you have another panic attack, it changes the diagnosis to panic disorder. Panic disorder means you are constantly afraid or fearful of having another panic attack, and it can affect the occupational, professional, and educational or other important areas of life. So these are the different types of anxiety, the generalized, OCD, PTSD, and so on and so forth, social anxiety, and so on and so forth. So panic attack is the most severe form, and which, when it turns to the panic disorders, it can make life crippling. And I know people who can, it can affect their professional life, personal life. They can, ranging from losing job to losing relationship, and so on and so forth. It can be very, very severe. So panic disorder, as we said before, living in a constant state of fear, quality of life is affected, given up the activity because of fear of panic attack. They used to have it before. Like driving is a very common example, that the people give up driving because of the fear of having a panic attack while they are driving in the busy road. So could not do air travel. I don't know if people remember, in 2013, there was a 10-year-old British boy who was having a fear of travel, and he's supposed to travel during the Christmas time, and he couldn't do that. He was actually, this was on the social media and the newspaper, and it was very, very difficult situation. I treated this kid. His father was a basketball coach, but he got better, and finally he flew, but it was a nightmare when he was having severe panic attacks and even panic disorder. In fact, afraid of having a panic attacks and stuff, and this was prominently the fear of air travel. So he could not take the flight to go back to UK, but with the treatment, he was able to do that. So this is a question, of course, this is a little bit cumbersome to have a two-way communication, but I will just go over one sided. 30-year-old married, this is the adult male holding executive level job. This is also a real story, with chest pain, breathlessness, feeling of going to lose control or die for 20 minutes. Yeah, this is the panic attacks are usually lasting more or less 20 minutes. So he went to the emergency room. They did the ECG, cardiac enzyme, everything was in normal. He was discharged, and he was told that all the tests are negative. Patient had a similar episode a month later, the same thing, the testing done and everything, and he was given the clear bill of health, and he was discharged, saying that you have nothing. But this gentleman, in fact, after the second attack, he approached me and he came to me, and he was working in a high-level executive position in a multinational company, and he was about to lose the job. And I still remember this history was he was riding the bicycle on the beach road in the month of June, and because of dehydration, seemingly or syncopal, he fell down from the bicycle. He was taken to the emergency room and stuff. So this guy since then have started having a panic attacks and feeling very, very anxious and nervous, and could not leave his room and could not leave his house. So because of that, his job was at jeopardy, and when we started the treatment, there was an improvement and he started getting better. But by the time he started getting better, I mean, he lost his job, in fact, from UAE. But the good thing is, with his treatment, he got so much better, and he followed up with the treatment, and then he got a job in North Africa, even the higher level position, and he was very happy. He left over there. So these things are very, very scary. The panic attacks, panic disorders are anxieties, but they are very treatable as well. So the point is to early detection and early treatment is the key for success. So this is very important to keep in mind when there are physical symptoms. Of course, rule out the physical problem, but at the same time, keep in mind that if there is an underlying anxiety which is creating these kind of symptoms. So another example of anxiety is the post-traumatic stress disorder. This is an intense fear and anxiety. I mean, months following the trauma, presence of flashbacks of the event, and the avoidant from the similar situation, similar words, similar people, startle response, like the exaggerated response if somebody touch, or if somebody, touch you or talk to you or something. So fearfulness, unnecessarily unexplained fearfulness. This is the post-traumatic stress disorder. Obsessive compulsive disorder is like having the obsession, intrusive, unwanted, continuous thoughts. Like this can be many, many types. For example, counting the numbers again, counting 3 before riding the bus or riding your own vehicle, or going 3 steps forward, 2 steps backward, hand washing, like fear of germs and those kind of symptoms. So they are also anxiety is associated with if you don't do the rituals. But if you do the rituals, you feel better temporarily. So the hallmark is unwanted, intrusive thoughts, and they are very uncomfortable and painful if you don't follow the rituals. So there are other types of anxiety: phobias, irrational fears, social anxiety, speaking in public, separation anxiety, and selective mutism. In fact, we don't have much time, but I have treated 3.5-year-old boy who had a selective mutism. What does it mean is, initially he started not talking in the school, like preschool, KG1 something, and then he stopped talking to his father, and then he stopped talking to his mother. So by the time he arrived, he was almost 4 years of age, and he was not talking in any situation. So we started the treatment. You will see it was a very, very difficult. He just stared into your eyes and things. He didn't have autism or anything. As you can see, there was reciprocity and communication other than speaking. And he lost the speech while he was developing normally and talking normally. With the treatment, even a very, very low dose SSRI plus the psychotherapy treatment, he got better within a couple of months. And he first started talking to his mother, then his father, and then in the school and nanny and so on and so forth. So there's a slight difference in the anxiety and fear. I'll just skim through it. Okay, so these are the helpful hints for the parents. Pay attention to your child's feeling. Oftentimes we are in the same room or we are in the close vicinity, but we don't pay attention to the child's face or his clothing or his gestures or his postures. So if we pay attention, we'll get a lot of information, and we'll see if the child is anxious or nervous or scared. We can support them. We can, help them to feel relaxed, or we help them to not feel insecure around you. So you stay calm if the child is feeling a little bit anxious or there is a situation. like something, any situation in the school, home, or on the way from school. So try to stay calm, recognize and praise small accomplishments to build the child's self-esteem and self-confidence. Do not punish mistakes or lack of progress. There was a study actually which was showing the rewards works better for the children as compared to the punishments for behavioral modification. So be flexible and try to maintain a normal routine so that they are not rushed to do things and the kids take their time to get ready or to process informations. Modify expectations during stressful period. Plan for transition if there is a lot extra time for that. So anxiety disorder, bottom line is anxiety disorders are real, serious, and most treatable psychiatric conditions. So psychotherapeutic treatment of anxiety is very well known, the CBT and, CBT individual therapy in certain cases, and psychodynamic is also helpful. Medication treatment for anxiety, mainly the SSRIs, or in certain cases, in very rare cases, maybe you can use very low dose benzo, like long acting, like clonazepam something for a short period of time. Combination treatment is superior to either treatment alone, means the medication and psychotherapy is superior to either treatment alone in severe cases, So CBT, what is the concept? The dysfunctional thoughts lead to extreme emotional state that can lead to maladaptive patterns. So this addresses the negative view of past, negative view of future, and negative view of the self to help correct the maladaptive pattern of thinkings. The negative thoughts are replaced with the positive thoughts during this therapy. So exposure versus response prevention, usually for the OCD, obsessive compulsive disorder. Gradual exposure and flooding is another way. I really don't, I'm not in favor of flooding, but the gradual exposure is one way you can try. Exposure versus response prevention is the best way to have. So the medication treatment is SSRIs, the first line drug. Rarely in severe cases, maybe we need short time benzodiazepine, tricyclics in very, very severe cases when treatment resistant, and ECT or TMS may be helpful in this kind of cases. So I will stop here, give few minutes for the question answers. Any questions, any comments, anything, please. Welcome.
My name is Dr. Dalal. I'm one of the new developmental pediatricians here at KidsHeart.
Dr. Al-Suri.
Yes, how are you?
Thank you very much. Thank you for being here. You are one of our speakers for the upcoming 17th. My girls will reach you, okay? Please be ready.
Inshallah. Thank you for
Thank
that
you. Thank you.
lecture.
Please.
This was excellent. One of the kind of diagnoses I struggle with, Dr. Tahir, is the selective mutism. I feel
Okay.
it's so difficult to treat, and I usually rely on psychiatry to kind of it help me kind of manage these cases. With regards to an SSRI, is there a specific SSRI that is your go-to for selective mutism?
Let me share with you. And this is just a general anxiety. So I will quickly try to do the just, and I know exactly what you are asking. All the SSRI, the first line is they are all more or less the same with the different colors. But there is a certain, the subtle differences and also the tolerability. As you know that our first line is that if there is a family history and somebody is already trying the SSRI in the family, it's better to use the same, not to try another one because it's already been tested. Because some people, and in the children, actually, for the sake of time, I will not go in detail. For the children, I feel the low potency, like the Zoloft, sertraline. Sertraline is a low potency, and we can have a luxury to divide into a smaller doses, so that is preferable for the children. And remember, I discussed, I mentioned the case 4-year-old. I used Zoloft 6.5. So we started with the 6.5, we went to the 12.5, and he showed 5, but then we tapered down in like 3, 4, 5 months when he started feeling better. But in SSRI wise, no, not much preference. Low potency for the younger children. Cipralex is good, but the escitalopram, it is good, but it can be sometimes activating. For the OCD, they are saying fluvoxamine. Fluvoxamine, Luvox, fluvoxamine is really helpful. But in practice, I did not notice much difference in that. The
Okay.
others are like Paxil and those medications. They are a little bit causing sedation, and but SSRIs are case by case basis, I would say.
Do you feel
For
like
the
they work
selective
well for selective mutism? Do they work well?
SSRI, yes, of course, they usually work well. They usually work well. I mean, I have seen quite a few number of cases. I mean, this was the only child who was very young. I have even seen a 17, 18-year-old boy actually. He had a selective mutism after severe trauma, and the biology is not the same, but at least we have some of the common symptoms in them. So this 17-year-old boy was having a severe trauma. I didn't want to go in detail, but very severe trauma, and some of the even the PTSD symptom. And he stopped even talking to the family members. And even in my session, when the family brought him, he was just sitting and staring at me. And I knew that he has a reciprocity, and he was not having a autism, and his prior functioning was very good, high functioning kid who was doing the okay in the class, like average grades and so on and so forth. So he was treated with the SSRI plus the psychotherapy, and he showed improvement in a couple of months, 2-3 months.
Okay.
Yeah.
Thank you for that.
Yeah.
Thanks, Dr.
You're
Tahir.
welcome. You're welcome, Dr.
Just a question, Dr. Tahir.
Please.
We face in our life so many occasions where we feel nervous. What's the difference between, being nervous? Let's say my boss is shouting at me, my wife is screaming at me at home because I'm late and so on, or I am under, starting arguing with people. Could all of these kind of things bring an anxiety or bring a panic attack by itself? Can I reach that point?
This is Dr. Suleiman.
I guess.
This is my boss. So how I can answer to my boss? I need to be careful,
Yes,
Okay.
Yes, sure.
So thank you. I know you're asking for the audience, and maybe you are testing me. In fact, there is a difference in the isolated events and the recurrence. If in some one incident, like the wife is not in a good mood and we didn't buy the things she needed and she became a little upset, and we have a tense environment at home. But I mean, it changed half an hour, 1 hour, 2 hour, we de-escalate and do things go normal and everything is fine. And we are going shopping together, is fine. The same thing is with the boss. For example, he gave us a task and we forgot and we couldn't do it. And we just delayed, and he sent a strong email or he yelled at you or something. And then after that, we catch up things, and next day he's normal, we are fine, and we are waking up normally. It is not disturbing our sleep. It is not disturbing our relationship. Then this is fine. This is normal daily life. The key thing is the recurrent incidences of like this, they are increased risk factor for developing anxiety later in life. So if these things keep happening again and again and again, then the resilience comes. For one person, this kind of 10 incidences can create anxiety. In another person who is more resilient, 15 of such incidences can create anxiety. When I say the clinical diagnosis of anxiety, this means it starts affecting our life, like our personal, professional, educational, or other important areas of life. It starts affecting us. For example, we become anxious, we cannot drive on the road. We become anxious, we don't want to come out of the home. We become anxious, we cannot take a flight. We cannot take certain projects. So those are the clinical anxiety forms. Those need to be treated. But one day, the simple isolated incidents here and there, and which is not affecting us, they should not be treated. But at the same time, we need to find the coping skills to deal with those things and try to learn the healthy habits, like not smoking, exercising, as you always tell me, healthy eating, and the relaxation techniques. So all these things are very, very helpful to de-escalate or decompress ourselves whenever we have time and opportunity, so that we don't reach to the point where it becomes the clinical anxiety diagnosis, where it starts affecting our personal, professional areas of life. I hope I answered the question.
Thank you very much. One more thing, kind of follow up with the previous question. The stress, could we label it as a request for developing an anxiety as well? Like I am stressful, 20 patients and I cannot cope up with my notes, and I go home late and I sleep late and I wake up early and all of these kind of things. Could that be a form of anxiety?
I missed the part because there was a communication break, but I understand the concept. Like you're asking that if somebody is overworked and less time for rest and less time for sleep, that can be a risk factor. You know, in the present day, fast-paced life, we professionals, you know that we are on the overdrive. We are working more hours, taking less rest, and still we are coping with it. So in fact, I mean, this is a very complex and multitude areas in the anxiety symptoms. For example, some of the tasks, they are very stressful, but at the same time, they are relaxing. For example, when you are seeing the patient, you have a 2 patient, 3 patient, 4 patient, they are waiting in line, and you are seeing one after the other. But in the same time, one patient comes very, very thankful, and they are saying, "Oh my God, we are so good that we see you and we have a treatment, and now we are much better, it changed our life and even our family's lives." So this positive remarks is a lot of relaxation qualities in itself, and it will help you to de-escalate and create a positive energy in you. And so this is thing, the stress is like filling the part of the stress and also losing the stress, like by these kind of remarks and positive positive things, positive attitude from the people. So this is keep on going, and it's a very complex to keep measure of it. So I think the only thing you can measure is that if it starts affecting and bothering you and start affecting the work, then it is a clinical, really we reach to the point where we definitely stop and think about it and get the treatment. But it's also a lifestyle. You know, throughout life, we cannot keep seeing the psychotherapist or psychiatrist throughout our life. I mean, we need to develop the healthy, balanced lifestyle in which, like, we get stressed and de-stress. We need to learn our own way to de-stress ourselves. Yes, stress is a risk factor, and de-stressing is a beneficial part of the equation. So I think we need to have a positive lifestyle, positive thinking. And you know that, I mean, there is a full lecture on this one. Giving is taking. This is a message for all my audience. They will think about it. What does it mean? And if they know, they can message me, WhatsApp me. Giving is taking. It's a big time, evidence-based, and try to adopt that as well. It is very, very helpful.
I'm Dr. Abdul Latif, my graduate. I'm working as a consultant psychiatrist in Abu Dhabi.
Please.
Oh yeah. In UK, we use ECT, you know, in a very limited occasion. So it's a treatment which is reserved for severe depression, and also we use it in mania, severe mania. And do you people use ECT as a treatment for anxiety in US?
Let me share with you. I mean, not only ECT, very, very severe, extremely severe anxiety cases, the surgery has been used. Did I surprise you? The psychosurgery, the brain surgery for OCD, right? For OCD. So in very, very severe cases, the ECT can be used, you know, I mean, although it's not FDA approved, and but there are off-label use for this one. But we are talking about very, very severe where they failed the SSRI, of course, they failed the atypical, they failed the benzo, and it's very, very difficult. And sometimes they need a propofol. You know that it's just
propofol.
So in those cases, but those are very, very limited cases. I don't know how many of them are the OCD cases as well. They have the anxiety on top of these very, very severe OCD, which is a life crippling. So that's why we need to mention that. But the ECT, there has been less and less use of ECT as well as in US. As you know, the TMS is FDA approved treatment entity. It is very safe and very helpful. It is approved for the mood disorder and for depression only, but off-label use for other areas as well. For example, addiction, for the mood disorder, and so on and so forth.
All right, Dr. Tahir, I think we don't have any more questions.
Thank you. Thank you very much. Thank you for everybody for your time and your patience. I would love to have a feedback, please, because we want to always learn from our colleagues and our associates, and we want to improve ourselves. Guys, thank you very much. Any comments, feedback is welcome.